Okay, it's 1 o'clock, so we will go ahead and get started. Good afternoon and welcome to today's webinar. It's hosted by the Georgia chapter of HFMA. I'm Laurie Hebe. I'm a Georgia chapter HFMA Education Committee volunteer. We hope this special Wednesday webinar series is providing value by giving you access to experts who can share their best practices that are going to help us now and in the days to come. If this is your first time joining us, we've had several presentations since the beginning of April. A couple of those have been related to COVID-19 financial reimbursement. Of course, this is a moving target, but I think you'll find that our presenters have given a ton of resources that you can check for the latest updates. So the link that I've posted in the chat box here for Jordan's presentation is also the link that you can use. All of the presentations are in the same area. There's a folder called 2020, and you can download, as I say, Jordan's presentation today and the presentations that we have done already for the past several weeks. So for today's presentation, we're pleased to have Jordan J., Vice President of Operations for Patient Matters, who will discuss best practices to revamp the patient medical billing experience to prevent surprises. Before we get started, let me just review quickly a few housekeeping items. All of your phone lines will be on mute to avoid interruptions during the broadcast. Please submit your questions via the questions box. You can do that at any time, and I'll keep up with those and coordinate with Jordan for his answers at the end of his presentation. As I mentioned, the presentation is available now. You can download it, and I also will send it out in an email at the end of this week. For today's call, everyone is eligible to receive continuing education credits for participating. So again, be on the lookout for the email that I'll send later this week. It will include a form for continuing education. You can use this form to self-submit for your credit on the HFMA national website under the membership info tab. For today's presentation, it's my pleasure to welcome Jordan J. Jordan has more than 20 years healthcare experience with a focus on revenue cycle, project management, process development, health information management, and physician practice management. He's been with Patient Matters, which provides patient financial management services since 2014. In his role as Vice President of Hospital Operations, Jordan works with health systems to help them better manage patient cash collections, including point of service, balance after insurance, and self-pay, as well as to develop programs to enhance the patient experience. Before joining Patient Matters, Jordan was Director of Patient Access at Eskenazi Health in Indiana. A lot of access, sorry, Jordan, sorry about that. But anyway, we are ready to begin, so I will turn it over to you.
Great, thank you, Laurie, and thanks to everybody who's joining me today. Just a point of reference, if you hear some background noise, we're unfortunately experiencing a major storm at this moment, so I apologize in advance for that. So on today's agenda, we'll talk about some of the challenges around surprise billing. We'll talk about how that fits in with our current pandemic of COVID-19. And then what are some of the types of tools that we can use to define a better patient experience? How do we help the patient understand their benefits? Which parts of the new legislation that has recently been passed in Georgia, which parts of them are applicable to the patient's surprise billing understanding? Also, how do you use data to understand your patients better? What type of patient behavior can you influence by creating customized or personalized patient financial experiences? Innovative tactics that can be used to limit your patient's exposure to surprise bills, and these can be in the form of price estimation or propensity to pay data, prior authorization, etc. And then what impact these items have on the patient's overall satisfaction or dissatisfaction with your services. And finally, we'll talk about some strategic impacts of surprise bills and the tools available on the marketplace. And then we'll close out with where do we see this going forward. So let's start with just defining what a surprise bill is. And there is a lot of confusion around this topic. There is what providers understand surprise bill to mean and what a consumer or a patient understands that to be. As a patient, if you are rushed into the emergency room because you're suffering some sort of a life-changing event, and then you have surgery or other services provided at the hospital, you may not know that all of those physicians and practitioners that are attending to your care, if they are indeed contracted with your insurance and your plan. And so, and no one would assume you to know that as a consumer. Additionally, the hospital staff may not know that all those care providers are within your network as well. So the surprise bill comes in when care is rendered at a in-network facility by out-of-network providers. That's just a simple way of looking at it. And it occurs when an emergency care at a hospital is not within the insurer's network. Surgical procedures in particular, because we use anesthesiology services for those, they too provide a greater exposure to the patient, because at the time of registration, pre-registration, or at the time of eligibility verification for benefits, the information level that is provided does not get to that level of detail. So you present to the hospital for a emergent or urgent surgery that's scheduled, and your benefits may not indeed reflect that all of those care providers are within your network. And that can result in balance billing. And balance billing takes on different types of flavors. We've been doing balance billing forever, ever since we've defined what a patient responsibility is. And that balance bill can occur, if you're lucky, it will occur within a few weeks, but most payers don't adjudicate those claims for quite some time. And when the patient receives that balance bill, their self-pay out-of-pocket cost, and that can be way down the line, they may not recall all of the individuals that they have encountered as part of their service when they present it to a in-network hospital. So that's where the confusion comes in on the patient's part. And then we on the provider side don't have tools available easily that can help educate the patient. And we'll talk about some of these tools that can be used to remedy those situations. COVID-19 provides yet another layer of complexity. Many patients that have coverage have not encountered services until now. Lots of folks live their entire life and not go to the emergency room, thank goodness. And so they may be going to an emergency room that is in network, and then because of various care issues may get admitted to an inpatient bed. And those providers, are they in network? Is there a mechanism set in place to educate the patient? Bills from many outside the care location can cause a lot of confusion post-recovery. If you've ever had any type of scheduled service that includes diagnostics, you will get a bill from the hospital, you might get a bill from the provider, you might get a bill from somebody who read the x-rays and your CAT scan. There's a deluge of bills that come through, and you pay the first one assuming that your responsibilities as a consumer have been met. And then the third and the fourth one comes through, and that comes as a surprise. And so that's an example of how surprise bills can be a huge dissatisfier for the patient. And patients, by the way, they don't differentiate between the hospital and those contracted providers that you may have in your system. They look at the bills coming to them from you. And so the dissatisfaction or the need to price shop and go somewhere else gets heightened for the patient, because they go, well, I went to this hospital, it was to be in network, and here I am now sitting with 4 bills that have come to my attention that need me to do something with them. The self-pay community is a whole different group that gets left behind. If you don't qualify for charity and you don't qualify for any of the governmental programs, the self-pay community until very, very recently, and even today, don't have any clarity in a COVID environment as to what their outcome is going to be. A lot of insurers have relaxed or made proclamations about what they will cover, and that may be just an illusion. because we know when you work through these, what gets considered as a direct impact care for COVID-19 versus a comorbidity that may have contributed to that, and what's covered and what won't be covered is yet to be determined. The White House recently put out a news bulletin saying that testing and care for uninsured individuals would be covered. Currently, there is no mechanism in place to accomplish that. We don't know how that will be handled, and that is still evolving as we go through the pandemic. So coming into 2020, as I lived in Georgia for a few years, the conversation around surprise bill had been one of those that had been going on for years. And so it's good to see that now coming to a resolution, at least on the legislation part of the House. And there are a couple of bills that the House bill passed, the House side passed, and then there's a version for the Senate. And the House bill 888, which looks to provide patients with some coverage and some protections against surprise bill, requires a system to be set up that not only educates the patient, but if there is a conflict that comes out from an encounter at a health system, if there's a conflict of who is responsible for which portion of the bill, that conflict really must be handled according to the legislation between the payer and the provider, and the patient is only subject to the out-of-pocket costs that they would have incurred if they had indeed been for in-network services throughout the entire care continuum. So what is it intended to do in 888 is it's to help prevent people from receiving high hospital bills when they are unknowingly treated by a out-of-network provider in an emergency. You can also see how this could create some confusion for the patient as to what does the patient think an emergency is. In this legislation, that is defined as services as a direct result of presenting to the emergency room. We will require patients to pay no more than their deductibles, their usual out-of-pocket costs, their cost share, and then providers can request arbitration, and that fight is between the provider and the insurer. In House Bill 789, which also recently passed, it's part 2, there is a bill rating system that will be required for payers to advertise as part of their advertisement. If they do any kind of TV outreach or they do a online type of a advertisement, they will be required as part of their directories to list all of those 4 critical services and their providers at each of their in-network hospital contracts. So that's a good thing. As a consumer, not in a life-threatening environment, you will be able to get to that information to see if you do present to Hospital X for these services, who are the providers that are covered within that network. And then there is also parts of this is also applicable in the Senate version of the bill. And there's obviously going to have to be some reconciliation before it goes to the governor for his signature. But both of these House bills and the Senate bill track pretty tightly. So there isn't really too much separation between the two, and the language has been really well coordinated between the 2 chambers. So in this bill, which is 789, again, it covers those 4 core areas. Insurance companies are required to keep a directory that is available to the patient. In the Senate version, it's very, very, very similar, provides a mechanism for resolution, which is what the House bill does as well. It requires the Department of Insurance through the Commissioner's Office to request all payer claims data. And the reason for that claims data, by the way, is that when there is a dispute between a provider and a payer, those claims data will be used to create payment models, and each parties will be required or can present their payment model, and then the commissioner, through arbitration through that office, will make a ruling as to which payment model will be accepted for that care. So what does this mean for the patient, which is who is really at the core of all of this legislation? It does require, in many cases, from the insurer to pay for a clinician at a hospital that is not within the network of medical providers. Again, this is the same situation that I just mentioned earlier. A patient presents to the ED, which is in network, but then there's some service providers that are not. In this case, the legislation will protect the patient from financial responsibility beyond what they would have normally paid in their co-pays, co-insurance, and deductible. And that can be, as we all know, thousands of dollars already. And then if you take it forward and the patient is subject to out-of-network benefits for certain parts of their care, that can add a tremendous amount of financial burden. And that is what the law is attempting to remedy. So as we all know that the healthcare financial landscape has been shifting for quite some time. The patients are becoming much more knowledgeable and should be about the benefits that they receive. And so that creates consumerism to some degree. Patients call around for the same services and the cost can vary dramatically from one location to the other. And patients are willing to drive distances if they feel that they can have some savings. And we'll talk about how you can help educate your patients, create a better patient experience to reduce the amount of bleed from the volumes that you may experience if you don't change anything in how you do business. The financial responsibility has been shifting and continues to shift. So if you look at, just as an example, in 2000, the patient's responsibility was around 5%. And then here in 2019, just last year, that has shifted to about 35% of total cost. And what that does is not only is that burden shifting, at the same time, healthcare organizations are searching for solutions to meet the patient's demands, and they're wrestling with the same market share. It's not, very few market share areas are growing at a rate that keeps up with the increases in patient responsibility. So you're competing to retain the patients you have. You're seeking to differentiate by providing a superior customer experience. And we'll dig into that here momentarily when we talk about the pre-access model and its function in retaining patients and creating a much superior level of attention so that you can see how that can have an impact on your retention of patients. On an average, a family is seeing an increase of about 5% in premium costs in 2019 when compared to 2018. They saw that, and they're spending about $20,000 in premium costs, whether they're doing it through direct contributions or through a employer deduction. And nearly a quarter of insured patients have a deductible that's greater than $2,000. When you look at those two things, the cost continues to increase overall, and you have an insurance plan that on an average has $2,000 or greater in deductible. And then you see that the average savings for 2/3 of our population is less than $1,000. That is a recipe for disaster. We are seeing that unfortunately play out live on television every day through this COVID-19 pandemic. You're seeing people who have been, most individuals have been living paycheck to paycheck. As soon as there is a disruption in those finances, they are very close to financial ruin. And if they have no savings to back up, and that is defined as less than $1,000 currently, that is what is driving a lot of these conversations about paycheck supplements and what the role of government is. There UBI that should be considered. So lots of conversation around that, but we're seeing, unfortunately, this scenario play out in real time at the moment. Our overall expenditure for cost of healthcare, the national healthcare cost also continues to grow. You can see in 2016, it was 3.3 trillion. And then here projected in 2021 to be 4.26. So overall, we're spending more, and yet the patient's cost from the government, they're spending more, and the patient's cost as well continues to grow. For example, in 2017, compared to 2018, we saw an increase of out-of-pocket costs for inpatient services increased by 14%. And that is a huge increase year over year. The patient's deductible and copays averaged a little over $4,600 in 2018. When you look at that against 2017, you see that that was a little over $4,000. So you see huge growth in the amount of cost passed on to the patients. You know, like I said earlier, in year 2000 rather, you saw responsibility for the patient at 5%, and then in 2019, just 19 years later, you're seeing it at 35. That is an unsustainable model. Something has to change, because at some point, that is going to be cost that patients simply cannot bear. So all of that to say, how do you understand your patient's financial responsibility better? What are some of the things, some of the items that you need to do to create a complete patient financial profile? You have a lot of data available. Lots of hospitals and providers are using propensity to pay data, which can be confusing at times because it gives a lot of information and may or may not be actionable. And then in what ways are you presenting that information? Do you present it to your staff in a way, in a hospital, if you're on the provider side, do you present it in a way that can be easily put into an operational workflow? And do you need to create payment plans that a patient can manage? What is the best way to do that? Is it better to combine all previous accounts into a single payment plan that a patient can bear and increase the duration and have lower default rates? I know a lot of hospitals have fairly aggressive collections policies that's based typically on balance, that indicates that if your balance is under X, the duration can only be these number of months. In this age of COVID-19, we are recommending that you look at your collections policy to see if you need to make some adjustments. Even patients that were not defaulting on their payment plans may be at a much higher risk to do that now. So perhaps the duration should be increased to lower the premium so that there is better compliance and less default resulting in bad debt or collections. The role of price estimation tools, and those have been on the market for quite some time. Price estimation adds a tremendous amount of value, but you want to be able to use it correctly. Lots of price estimation tools on the market will let you do estimates based on the primary CPT code. You enter a CPT code, it looks at your CDM. It may or may not look at provider behavior. As we all know, you may be in one service line, and how a provider does a particular procedure can vary vastly. For example, I used to work in orthopedic surgery for many years, and we had multiple providers in our office, and a single provider may use a exogen implant versus another. And so you have to be able to account for all of those nuances to be able to give a patient better understanding of their financial services ahead of service. And that's the key, because you're looking at, in the ED, when you're looking at things, that's in a much tighter timeline from the time the patient presents to the time the patient is actually attended to by care clinicians. In a scheduled environment, you do have the luxury of a little bit more time, so you can do a little bit more to help educate your patients on their financial responsibility, identify for them what some of the pricing includes. We use terminology that's unique to us in the healthcare field when we're talking about payments and collections and copays and deductibles and coinsurance. A lay person may not understand the benefits, the definitions behind each of those. So it is always a good idea that your estimation tool, when you do use them, not only does it do primary CPT estimation, but it also takes into account all those wraparound services that are rendered as part of that service. The other is, the key thing to keep in mind is that the payer coverage, the information on how best to ensure all involved parties are covered. This goes back to the whole topic of surprise billing. As the burden gets increased on the payer, it too will get increased on care providers. You will have to have a mechanism in place to be able to, with confidence, assure the patient that all participants in their care are indeed eligible to be in your in-network benefits. And then there's the option of giving patients the ability to do quick estimates or self-service estimates. And these are typically to give them a very rough idea, because a patient will not know the information around wraparound service or provider behavior. But if you provide a tool online where one can go in and enter a description or a service code and a diagnosis code to come up with a understanding of what their benefits may or may not cover, that is a start. You do want to have a tool that does takes into account additional behaviors such as providers, history, their adjudicated claims. If one were to be billed for a knee arthroscopy, for example, what is the average cost of that to the consumer? So those are the types of things you need to account for when you're trying to improve the patient's experience and also help reduce the surprise billing. In the ED, because it is challenging, you may or may not be able to do a quick estimate because you don't know how the care is going to unfold, unlike in a scheduled environment. So in the ED, we always recommend having some type of tool and information available that looks at either severity of care or looks at various E&Ms, et cetera, to give the patient an average out-of-pocket cost for what they're presenting. And again, that is very challenging, but all of us have the ability to look at adjudicated claims for whatever the primary chief complaints were that a patient presented for and what the average cost for those could be. And then taking advantage of automation with best practice workflows. And this is important in the sense that you want to create a workflow that's short and simple, because short and simple always gets you higher compliance. There's a lot of automation available that you can take advantage of. Everybody's probably on the provider side to some degree using 270, 271 transactions for eligibility. How will those be enhanced to comply with some of these requirements for in-network assurances for participants of care? And then try to automate only things that make sense. There's no point in over-automation if it's going to just add additional or erroneous time into your workflow. A good workflow really should be wrapped around the patient's need for communication. And then that communication can lead to financial planning. And then finally, what is the strategy that you have in place to be able to secure payment either prior to service or at the time of service? So the benefits of a good automated system with good workflows, it provides the patient the ability to understand their obligations in real time. And that's important because, as we know, deductibles can change based on claims that have been submitted to the payer, and those are typically updated once or twice a month. So when you are soliciting payment and you see that the patient's responsibility is higher than their deductible identified, you need to be able to explain that to the patient for them to understand why it is that you need to collect on those at the time of service. Offer payment plans that are tailored. I've mentioned that before. It is good to have a clear understanding on the patient's debt to income ratio, some of that type of data that you traditionally receive from propensity to pay, and be able to build on that to be able to give a simple financial score. Propensity to pay, as we all know, gives a lot of information. You need to be able to have a tool or a method that distills it down to a simple score that then can be actionable. And it also hides all of that financial data behind the scenes so that frontline staff don't have exposure to them. And then finally, you want to be able to connect those uninsured patients to any type of programs that are out on the market, whether it's PPA, CAs, health exchanges, or Medicaid programs. And then if charity is an option, you obviously want to be able to pursue that as well. So we at Patient Matters for years have worked on a approach that takes the most progressive look at a patient's financial experience, and that is through our pre-access service center model. And that model has been out on the market for quite some time. There's variations and different nomenclatures that people use to describe it. Some call it complete financial clearance, others call it a pre-access service, some call it pre-registration co-location with other services, with financial planning. So there's a lot of names that people use to describe it, but ultimately it just really comes down to this, which is how do you use your pre-access center to educate your patients and collect for services being rendered. So typically in a pre-access service center, the agent or the service agent from the pre-access center will call or have some type of communication at least 3 days prior to service. We always recommend you keep that window short, but not too short so that if one has to be rescheduled for service, they don't have the time to do that. If you do it too far in advance, then you have to make yet another additional call to follow up to remind the patient and confirm those types of information because they may have changed. So we always recommend that you do it 3 to 5 days ahead of time. We have entities that we work with that do it further than that to give the patient an additional opportunity to be able to meet their financial obligations prior to service. And then it moves from that contact phase to the verification phase, which is really taking the information as it relates to health coverages and explaining that, running bill estimates, giving the patient access to any kind of information that can drive them to a better outcome. It helps them reduce their anxiety and be fully prepared for their responsibility when the bill does come. And it also provides the hospital and service providers some assurances that the patient understands their responsibility. And all of that leads to pre-registration and then on to navigation. And that's what you're seeing here on my screen. So the pre-registration pathway, we try to define it in a way that it creates for the patient a unique path forward. Patient navigation. How do you get them from the point of presentation where they present to the service area that's going to provide the service? We use a patient navigation scoring model that we refer to as no stop, quick stop, full stop. And this model is used to limit the exposure of the patient to the general public. So if I am someone who has been fully financially cleared, I've gone through the pre-access service center, I have no responsibilities to pay anything at the time of arrival, or I had a responsibility and I've elected to prepay for that service, I can proceed directly to the service area and then be authenticated for my ID and consented at that time of arrival. But those are the only things that I need to do when I present in that service area. In COVID-19, that helps you reduce the exposure, and not only to yourself, but also for the patient, more importantly. So patients, unlike those of us who are working on the provider side, at a hospital in a hotspot, we may be fully PPE'd. The patient is just coming as they're coming. So their exposure is significantly higher versus our own. So we want to make sure, is there a way to use the pre-access service center? Can you route them to their care destination and not have them co-located in a very large lobby with hundreds of people? A quick stop is just one step below. These are individuals that have cleared through the financial process, except they've elected to pay for their service at the time of arrival. And then finally, you've got those that were either unwilling or unable to participate in the pre-access model, and they will go through the traditional pathways that a patient access registration creates. The point of patient navigation is speed to care. Think of it that way. When the patient presents, you want to get them as quickly as you can to their service area. And this is all a result of our pre-access service center model. Anytime you run any kind of a business, you do have to have accountability and continuous improvement, and that relies on analytics. You have to have lots of data to make these decisions. If you're trying to create a patient profile, patient financial profile to reduce surprise billing, you have to have some of these tools available to you, estimation, propensity to pay, or enhanced versions of propensity to pay that are simply looking at scoring. And then it's always a good thing to know your volume, because you want to be able to see if you have any kind of volume loss with the changes that you might put in place. Keeping an eye on your patient's financial outcomes is another good way to know, by looking at denials and those trends. Are you getting less denials since you changed your methodology? Or are you getting more denials and higher dissatisfaction? So you know there's some kind of a disconnect there. And then also looking at your point of service collections or pre-collections combined with point of service collections to see what kind of outcomes you're receiving from those. Prior authorization is yet another complexity into the healthcare landscape. You've already had to address surprise bills. You're using estimation and propensity to pay and eligibility data to educate the patient and reduce your exposure to bad debt. And then prior authorization adds yet another layer of complexity. And so as you can see, most providers find this process to be very burdensome. And they're spending a lot of money and a lot of time in trying to remedy that situation. I was not surprised, but I was amazed to see that 92% of all non-clinical care delays are because of patients waiting and providers waiting for prior authorization. That is a lot of unnecessary delay in care that can be avoided if you have a tool that helps address prior authorization. And one of the key things, the key components with prior authorization is really making sure that your tool can accomplish the three critical steps, all three of them. The first one being determination. Why go any further if once you have gone through the determination phase that a authorization is not needed? A lot of the provider side is still doing the traditional work of prior authorization the same way we had been doing it 25 years ago. Pick up the phone, call the payer, talk to somebody who's the benefits person, and then get passed over to someone who's going to make a determination for medical necessity. And you spend a lot of times, like I said, on an average, about 27 minutes to manually work one account, costing you a little over $11. Costly and timely. And using a product that can help you make determinations in real time within seconds can help you reduce the number of accounts that you have to work through other mechanisms. But that's an incomplete solution. You need to then be able to have some sort of automation that can take the determinate accounts, those that have been determined to need a prior authorization, to the next stage, which is submission. Typically in that process, you will have automation that will take you over to the payer's website, log you in, it will fill in all the information that it can, and then it will abandon the process once it has been submitted. That too is an incomplete process. You really need the third one, which is also the determination phase for results. So that is your resolution. What did the payer say that they needed from you to do further? Or here's a tracking number, or here's an authorization number. So you really need all three: determination, submission, and retrieval of the result. At Patient Matters, we have been working in this space for quite some time. And as you can see, we've helped create simple workflows. Our goal is always to reduce labor cost and to reduce the time to authorization. Both of those are critical. In several of our clients, we're able to actually reduce that time by up to 60%. You need a solution that can be easily embedded or can easily work with the leading EMRs on the market. And then you need folks that can give you some advice as it relates to prior authorization, how to make that process work. Do you have advisors and help desks that can work through those? Someone who understands that can help you prevent denials. And then some reference guides that can also be used to educate your patients and your staff. I know that's a lot of information that I have rattled off in about 40 minutes. And some of the sources that we used for this information is not just our own experiences working with multiple health systems across the country, but as you can see here, if you're interested in reading some of the articles that we used for data sources, they're advertised here. And then finally, if you'd like to engage with us, you can visit us at patientmatters.com. If you have any emails, my email is listed in the presentation. Lori, with that, I will hand it back to you to see if we have any questions.
Okay, great. Thanks, Jordan. And just a reminder, everyone, if you want to use the Q&A box to submit your questions, that would be great. The first question I have here is, if you would please, Jordan, review some of the service areas covered by surprise billing.
Yeah, and so there is confusion around that, particularly on the patient side, which is, they hear the word legislation will protect me around surprise billing. They assume it's an open access network all of a sudden, and that's not the case. It really, for Georgia, it really is geared towards emergency services only. And the 4 core areas that it defines is anesthesiology, pathology, radiology, and emergency room, but all from the direct impact of seeking emergency care.
Okay, next question. So talk about some of the carve-outs to the legislation. For example, what about employer self-funded plans? How are they covered or accounted for?
Yeah, and so very good question. So employer-funded plans, those are what that are referred to as self-funded TPAs. They are not covered under the surprise bill legislation that have recently passed in Georgia. So if you have a employer that is taking on all the risk and cost for your healthcare, but is using a TPA to just administer those on their behalf, the employer is really on the hook for whatever cost you may incur. And those under the state regulations cannot be changed. They're managed by a different federal entity and they're not impacted. The law has no ability to do that. So those, if you are in those, unfortunately, you would not be protected from surprise bills.
Okay, thank you. Again, just a reminder, everyone, please use the Q&A box if you have a question. All right, here's another question. How is data used to create a patient financial profile? How do you know if the patient is a candidate for government or other type of charity program?
Yeah, and so most hospitals are using either financial counselors or they're using a third-party advocacy company. We've been in that business for a long time as well. Or they're using propensity to pay data to kind of get a better insight into the patient's financial performance. And what I mean by that is when you look at a traditional propensity to pay response, it will give you details around debt to income ratio, what percent to the federal poverty line is the guarantor, what type of credit they may have available in that space. And so using that kind of information also lets you know if a patient may be at a poverty level that may be applicable for charity. Charity is always an option for most hospitals as well. They have very good processes and definitions around that. So if you are eligible for charity, that's yet another way. But looking at the patient profile, looking at their patient data as it relates to their financial performance previously within your own health system also can be valuable. So you want to get a deeper look into a person's financial performance, but you want to also be able to do it quickly and then do it in a way and present that information in a way to your frontline staff that is easily digested and that they can make a quick decision. And that can be challenging if you don't have some of those pieces that I just mentioned.
Okay, great. Okay. All right. It looks like that is our last question. So Jordan, thank you so much. Just a reminder, everyone, that our special Wednesday webinar series runs now through the end of May. So please be sure to join us next week at 1 p.m. The webinar next week is Best Practice Denials Management to Optimize Reimbursement. And be on the lookout for our Wednesday webinar emails. You can register that way, or you can also register via the events calendar on the Georgia HFMA website. Thank you all for participating in today's webinar. And Jordan, thanks again for sharing your expertise. As I mentioned, you can, if you haven't done it already, you can use the link in the chat box to download Jordan's presentation. It's already posted on the Georgia HFMA website. We will also post the recording of today's session. That will be done by the end of the week. And then also by the end of the week, please be on the lookout for an email from me. This is Laurie Hebe. And that will contain your CPE credit form, which you can self-submit on the National HFMA website. So thanks again for joining us today. Stay safe, everyone. Jordan, hopefully the thunderstorms have passed, and everyone have a great afternoon.
Great. Thank you so much. Have a good day.